All right, welcome to another deep dive. Today we are going to help you prep for the MRCS exam.
Yeah, we're going to be focusing on acid-base interpretation and dyspnoia investigation.
Right, two very important topics for any budding surgeon out there.
Yeah, absolutely crucial.
We're going to be starting off by taking a look at an ABG profile.
Mm-hmm.
Then we'll move on to the common causes of dyspnoia post-op,
Okay.
and then how we should investigate that and how we should manage it as well. And then we'll wrap things up with a case challenge.
Sounds good.
So let's kick off by having a look at ABG analysis.
All right.
You can see a sample ABG profile in figure 5.1 of the source material.
Yep.
So what are the key values that we should be looking at?
So the four key values you'll be looking at are the pH, the PCO2, the PO2, and the bicarb.
And these are the values that tell us if someone's acidotic or alkalotic?
That's right. Yeah, and the respiratory or metabolic nature of that.
And how do we interpret these values?
Okay, so the easiest way to think about it is to think of it like a puzzle. And so if we're going through the values, if the pH is low, that means less than 7.35, we're dealing with an acidosis.
Right.
If it's high above 7.45, we've got an alkalosis.
Okay.
And then we need to look at the PCO2, which is reflecting our respiratory component.
Okay.
So if our PCO2 is high, we're suggesting a respiratory acidosis. If it's low, it's suggesting a respiratory alkalosis.
All right, so we're already starting to get some sort of pattern.
Yeah, exactly.
The bicarb then tells us about the metabolic component.
That's right.
So if it's low, it's a metabolic acidosis, and if it's high, it's a metabolic alkalosis.
Mm-hmm.
Okay, so we're looking for patterns and connections between these values.
Yep.
All right, let's shift gears slightly and have a look at post-operative dyspnoia.
Okay.
So what are the most common causes that we need to be thinking about in the post-op period, say, a few days after surgery?
So there are lots of potential causes, but I think some of the most common ones you need to be thinking about are things like pulmonary embolism, pneumonia, myocardial infarction, pulmonary edema, bronchospasm, and pneumothorax.
And I suppose we shouldn't forget some of the less common things, like atelectasis as well, especially, in our post-op patients.
Yeah, and in patients with underlying lung disease and things.
Yes.
It's more common.
So that's quite a lot of differentials there. How on earth do we go about investigating all of these?
Well, I think, as with lots of things in medicine, the first thing is good history and examination.
Yeah, of course.
Paying attention to the timing of the dyspnoia and associated symptoms like cough and chest pain and risk factors for the patient.
And then what investigations can we use to kind of narrow things down from there?
So in terms of investigations, you want to be thinking about things like ABGs, a blood profile looking at white cell count, CRP, and D-dimer,
Okay.
chest X-ray ECG, and potentially a VQ scan or a CTPA.
And I suppose if we were concerned about a DVT as a source of a PE,
Yeah.
we'd be thinking about a Doppler ultrasound of the legs.
Mm-hmm.
Okay, so we've investigated it. What about management? Let's take two of the common differentials. Pneumonia and PE, for example. How do we manage those?
So for pneumonia, the mainstay of treatment is going to be antibiotics.
Right.
Obviously, the choice of antibiotic is going to depend on the organism that you're suspecting,
Right.
but you want to be acting quickly to control that infection.
And then with a pulmonary embolism,
So with a PE, anticoagulation is going to be key.
with something like heparin or DOAC,
Yep, or one of the newer oral anticoagulants, yeah.
in the case of a PE, is that always enough?
So it depends on the patient's risk stratification. So if they're hemodynamically unstable or they have a massive PE, you might be thinking about thrombolysis, which is essentially using clot-busting medication.
Right.
Whereas for stable patients with a low-risk PE, they might be suitable for outpatient management just on a DOAC.
All right, let's move on to the case challenge now.
Okay.
So we've got a patient with a history of alcoholic liver disease and atrial fibrillation, presenting with nonspecific abdominal pain and disruptive behavior. The ABG shows a pH of 7.3, 2 PCO2 of 3.4, 3 kPa PO2 of 14.4 kPa, and a bicarb of 17.
Okay.
So what are you thinking when you first see this?
So this ABG is pointing towards a metabolic acidosis with respiratory compensation.
Okay.
So we've got a low pH, which is telling us it's an acidosis, and a low bicarb, which suggests a metabolic cause.
Right.
And then we've got a low PCO2, which is the respiratory system trying to compensate by blowing off CO2.
Okay. It would be very easy to just put this down to intoxication,
Yeah.
given the history of alcohol abuse. But what else should we be thinking about?
So it's important to think critically.
Yeah.
While intoxication is possible, we can't just ignore the metabolic acidosis.
Okay.
So given this patient's history and presentation, a serious differential, like bowel ischemia, potentially due to a mesenteric embolic event needs to be excluded.
Right. So how would we go about doing that?
So this is potentially a surgical emergency.
Yeah.
So we need to resuscitate the patient, get a senior involved immediately, and then move on to imaging. So a CT scan of the abdomen is going to be crucial to look at the bowel for signs of ischemia.
Okay. And if that showed ischemia,
Then we may need to think about an emergency laparotomy.
are there any other calculations or lab tests that we could do which might give us more information?
Yeah, so calculating the anion gap can be really helpful in cases of metabolic acidosis.
Okay.
An elevated anion gap would support the possibility of a serious underlying condition like ischemia.
Right.
And a lactate level would also be valuable because an elevated lactate is often a sign of tissue hypoxia and could point us towards bowel ischemia as well.
So I guess this case really highlights that we can't afford to just rely on assumptions.
Absolutely.
Even when the presentation seems straightforward.
Yeah.
We need to think more deeply and consider all the different possibilities.
Yeah. I think this really highlights how important it is to combine our understanding of ABG interpretation with a high index of suspicion for potential surgical emergencies.
Exactly.
And that's how we make timely and potentially life-saving decisions.
Well, we've focused on some of the common causes of dyspnoea in this deep dive. But when you're prepping for the MRCS, make sure you think about some of the less common causes as well and how your approach might change in different patient populations.
Mm-hmm.
Because that's the kind of thing that's going to set you apart in the exam.
Yep.
Good luck.